250, 600. Está raro parar esto. Queremos ver, yo lo tuve atrás y 900, pero como no te cuento 5 pesos, me pagó a 700.
All right, I think we'll get started. Thank you.
Good afternoon.
Good afternoon. Happy Friday, all. So today we're going to talk about acid base. Like I mentioned yesterday, I love acid base. Just about every patient in the ICU will have an acid base disorder. So if you want to learn a lot about acid base, take an ICU rotation and you can practice a lot. It's pretty cool stuff, I think. Chemistry. All right, so I'm going to focus on really just an evaluation of acid base, how to work up a patient with an acid base disorder. I hope you guys did or watched the pre-lecture material. That has a lot of background information that's important, but I think this is better time spent in the classroom right here. So as far as naming acid base disorders, the first name is always the cause. So it always starts off with either respiratory or metabolic, and that's the overall cause of the acid base disorder. Second name is acidosis or alkalosis. So you can have a patient who has respiratory failure that present with a respiratory acidosis. Compensation. Does anyone remember what compensation is in terms of acid base disorders? Good. Your body tries to fix it, right? What's a physiologic pH?
7.35 to 7.35.
Good. There's a range, right? 7.35 to 7.45. For the purposes of acid base, just think 7.4. Keep it simple, okay? 7.4. Anything less than 7.4 is more on the acidosis side. Anything greater than 7.4 is more on the alkalosis side. And you're absolutely right. Your body wants to live at a 7.4, okay? It can get down to like 7.2, much lower than that as far as the pH. It's somewhat incompatible with life. You start to have major issues, the patient does. On the opposite end of that, once you get to like 7.55 or above, then you have some serious consequences. So your body really regulates at a very narrow range for it to function as it should. And those compensation will help make the pH more normal. So if your patient comes in with a respiratory acidosis, their pH is going to be low, maybe 7.3. Their PCO2 is going to be high. And then your bicarb, your body or the patient's bicarb is going to have to be elevated to compensate for that increase in PCO2. So it will attempt to restore that ratio to normal, but it won't completely become normal, okay? That's an important point about compensation, is that it'll never be back to normal to 7.4. If you have a 7.4 and a derangement in the CO2 or bicarb, there's probably some other processes going on. So it'll attempt to go to normal, but it does not completely normalize a pH. And importantly, these compensation, they're all predictable. So you can predict how the body will compensate. And if it doesn't compensate, maybe it's not fully compensated, or there's other processes going on. So primary acid-base disorders have only one major problem. So that's the simplest form, right? And we're going to start out with some practice examples of that. However, you can have mixed disorders, and the sicker the patient is, the more likely that they will have mixed disorders. And that's where it kind of gets a little bit complicated. So the compensation equations and the principles behind compensation will help you uncover some of these mixed disorders. So you can't have just about any combination of disorders with the exception of respiratory, because you can't have a respiratory acidosis and a respiratory alkalosis. Just as physiologically impossible to have hyperventilation at the same time as hypoventilation. Okay? So this is like, I think, the simplest way that I found to teach acid-base disorders. And it's a stepwise approach. I don't have 1.5 on this step like yesterday. So it just goes 1 to 2 to 3 to 4. So 1 is evaluate the pH. Always look at the pH first, okay? 2 is to determine the primary process. So what's changing that pH? Is it respiratory or is it metabolic? 3, I always say to calculate the anion gap. Now, you'll read some places they don't calculate the anion gap. I think you always should, because it can uncover a hidden metabolic acidosis if you don't calculate it. So some references or some people will say only calculate it in a metabolic acidosis. I'm telling you to always calculate it, because you can uncover a hidden metabolic acidosis. And then what you want to do is check the degree of compensation. And this is the hardest thing to conceptualize, I think. It takes some idea of the change in compensation, and there's equations that I'm going to show you. So it becomes a little bit more muddy, step 4. And then step 5, we're not even going to do. If you're on rotation with me in the ICU, we'd certainly do that. And I could talk to you about the delta gap and all. But we're going to start with just 4 steps, okay? And this is kind of a summary of everything that, how I teach it. It has the compensation equations here, which are also in the slide. So I would just, focus on the left-hand side, because you want to just keep it simple. All right, so step 1, we're going to evaluate that pH. How do we clinically get a patient's pH? Blood, right? You take a blood sample, send it off to the lab, and 15 minutes later, 20 minutes later, it'll be reported in the laboratory as an ABG, right? What kind of blood is it?
Arterial.
Arterial, good. Has anyone had an ABG drawn on them? I have. It hurts like hell. It's not a good feeling, because where's your arteries? It's deep, right? Yeah. So you have to go through some tissue, maybe some muscle, and it's not an unpleasant process. So the patient can feel pain. It could be difficult to get, so you might have to do a couple sticks to get that ABG. You have to get the blood and then send it down to lab, and there's some delay there. So it gives you one measurement at a single point in time. And remember, these patients can change rapidly. So once you take the ABG, send it off to lab, maybe get around to checking the results, the clinical status could have changed. So just keep that in mind, okay? But the first thing is look at that ABG, the pH on the ABG, and assess if it's normal, low, or high. So low would be what? Less than what number? 7.4. Always think 7.4, okay? 7.4. So if it's low, it's going to be less than 7.4. If it's high, it's going to be greater than 7.4. And then you have to determine the primary cause. So you look at either the CO2 or the bicarb. Now, do you want to look at the bicarb on the ABG or some other value or measurement lab? Why the metabolic panel?
Because the is a estimate.
It's a calculated.
Yeah, calculated.
So remember, on the ABG, you'll get pH, PCO2, oxygen, PaO2. You'll get a bicarb, but that bicarb is a calculated value on the ABG. The lab automatically calculates it by what equation? Henderson-Hasselbalch equation, okay? So a better value to get your bicarb would be on the Chem7 or a basic metabolic panel. That's going to report back sodium, potassium, chloride, bicarb, BUN, creatinine, okay? That's an actual measurement of the patient's bicarb in the blood. So ideally, that's what you want to do, is get an ABG and Chem7 or BMP, basic metabolic panel, at the same time. Use the bicarb on the BMP or Chem7. Okay, so you're going to look at those values. If it's high and you have a low pH, it's more consistent with the respiratory acidosis if the PCO2 is high. If the PCO2 is low and you have a high pH, that's more consistent with respiratory alkalosis. So if the pH is low and you have a low bicarb, that's more consistent with a metabolic acidosis. Okay? So you kind of want to know which direction these measurements, the PCO2 and the bicarb, are going to go for an acidosis or an alkalosis. Once you have that down, it's pretty easy. Any questions on this yet? Okay, so if the primary problem is respiratory, the PCO2 should head in the opposite direction of the pH. These are just rules of thumb, okay, to help you understand what's going on. If the primary problem is metabolic, the bicarb will head in the same direction as the pH. And you can use something like this. Think Rome. Respiratory, opposite. So the pH, PCO2 is opposite. Metabolic, equal. pH and bicarb, equal. However, you need to understand the changes, you know, either by a mnemonic or looking at the correlation. So every acid-base disorder should fit into one of these four quadrants as far as primary acid-base disorder, okay? So this basically says the same thing as the last slide. So if you have a low pH and your bicarb is low, that's metabolic acidosis. If you have a low pH and your PCO2 is high, greater than 45, that's a respiratory acidosis. Again, these are different, right? They go in different directions. Metabolic, they go in the same direction. Does that make sense? Any questions?
Yeah.
Do we have to memorize those numbers?
You don't have to memorize a number. You have to know the concept, right? So if I give you a patient's ABG on a quiz or whatever, you have to tell me what you think it is, whether it's an acidosis, alkalosis, and the primary cause, respiratory or metabolic. So however you can help yourself understand which way the things are going. So again, you can use, if you're into mnemonics and you remember Rome, R is for respiratory, O is opposite. So in respiratory, they go in opposite direction. pH is going to go down, PCO2 is going to go up. Metabolic, equal, M and E. They're going to go in the same direction. So for acidosis, pH is going to go down, metabolic, bicarb is going to go down. Now, oops. Well, we'll get there. Let's do some practice problems. All right, so for the first one, 7.42, 40 is a PCO2, PaO2 91, and bicarb is 25. Is that pH normal or abnormal? It's normal-ish, 7.42, right? It's kind of going up, but not that much. How about the PCO2? Is that normal? And what's the range of PCO2? 35 to 45. Excellent. For acid base, just remember 40. Okay? pH 7.4, PCO2 40. PaO2, you want it higher. We're not going to focus on PaO2. Bicarb, what's the range of bicarb?
22 to 26.
22 to 26. Remember 24. Okay? So this is basically normal. 7.42, pH is normal. Oops. 7.22. That acidosis or alkalosis? Acidosis. I already gave you the. All right. So now you have to say, is it respiratory or metabolic? So you look at both, the PaO2 and the bicarb. So you already know it's an acidosis. So what does the bicarb have to, what direction does the bicarb have to go for an acidosis? Low. Is that low? It's 1 unit low. It's not that low. So let's look at the PCO2. For an acidosis, what direction does a PCO2 have to go? High. And what's normal PCO2? 40. And it's 41, right? So I would say this is more consistent with the respiratory acidosis. Does that make sense? And that's a pretty good drop in the pH, right? 7.22. Remember, normal is 7.4. So you could even plug it in the Henderson-Hasselbalch equation, and that drop in the bicarb of 24 to 23, that's a very small drop. That's not going to change the pH from 7.4 to 7.22. All right, third one. Is this acidosis or alkalosis?
Alkalosis.
Good. See, this part's easy. All right, now you're going to look at the PCO2. Is that in the same direction as a pH? What's that? Opposite. So how about the bicarb? Is that normal, high, or low? Normal. So what do you think it is? Respiratory alkalosis. Does everyone agree with that?
Yeah.
How about up there in the back row? You agree? I agree. All right, last one. 7.28. High or low? Low, so it's a what? Acidosis. PCO2, high or low?
No.
And so, does that go along with acidosis? No. So let's move on to the bicarb. 20, high or low?
Low.
Does a low bicarb go along with the acidosis? Yes. So that would be a metabolic acidosis. So one other way that I think can help conceptualize it is always think of carbon dioxide as an acid. Okay? If you have too much carbon dioxide in your body, it's going to cause an acidosis. And then the bicarb is a base. If you have too much base in the body, it's going to be an alkalosis. If you don't have enough base, so the bicarb is 20, it's going to be more consistent with a metabolic acidosis. Okay, so if you think of carbon dioxide as an acid and bicarbonate as a base, I think that should help as well. Does that make sense? So compensation for respiratory disorders, so whether it's respiratory acidosis or alkalosis, your kidney is going to compensate, right? Because your lungs are responsible for carbon dioxide. So the elimination of carbon dioxide or the retention of carbon dioxide, it's all respiratory, right? So in order to compensate for that disorder, your kidneys are going to have to regulate the bicarb. So in respiratory acidosis, you have a high carbon dioxide? Yes. And to compensate, what does your kidneys do to the bicarb? Does it hold on to it, generate more bicarb, or are you going to eliminate bicarb? I'm hearing two opposite things. So remember, think of bicarb as a base. If you have an acidosis, a respiratory acidosis, you want to compensate and add more base, right, to the body. So is it going to hold on to bicarb or make more bicarb or eliminate bicarb? Hold on. It'll hold on, right? It will increase the reabsorption of bicarb or regenerate more bicarb, and probably both of those. Okay? So that the kidney is a compensation mechanism, the main compensation mechanism for respiratory disorders. Does that make sense? So if you have a primary metabolic disorder, so the disruption is in the bicarb, the metabicarb. So if we stick with an acidosis in a metabolic disorder, you won't have enough base or bicarb, right? The bicarb is going to be low. So let's say the bicarb is 12. To compensate, your lungs have to kick in and do what?
Hyperventilation.
Good. And explain that. Why are your lungs hyperventilating if your bicarb is low?
Because of pressure, partial pressure of. You see pressure. I don't remember how.
That's all right. So, okay, in metabolic acidosis, you have low bicarb, right? You don't have enough base. You have an acidosis. Your body doesn't like that. It doesn't want to be acidotic. It wants to go closer to 7.4. So in order to go 7.4 or closer to 7.4, your body's going to have to get rid of acid somehow. What's acid in this? Carbon dioxide. So you're going to hyperventilate to exhale more carbon dioxide. So eliminate more carbon dioxide through your lungs. Okay? Yep.
If you have like the alkalosis going like that, you affect the breathing, like you put a shallow the breathing, so you retain more carbon dioxide.
Exactly. So if you have a metabolic alkalosis, so let's say your pH is high, 7.5, and it's a metabolic cause, so you have too much bicarb, so the bicarb is like 34, your body needs to retain acid, right, to make the pH closer to 7.4. So if your pH is 7.5 or too much base, bicarb, your body wants to retain acid. So you're going to hypoventilate and retain carbon dioxide. Okay, this principle of compensation is so important. Anyone have any other questions about compensation? So remember that we can predict compensation. And by predicting, I mean using these equations to predict the change. So they are predictable. Your body will never overcompensate. And it will not fully compensate either. So you're never going to have a normal pH, a 7.4. The respiratory compensation takes minutes to hours. So the onset is pretty quick. Minutes. It's going to peak in hours. The kidney compensation takes days. Why is that? So why, for the kidney, why does it take so long to compensate? What does the kidney regulate? Bicarb, right? The kidney regulates bicarb. So why does the kidney take a long time to regulate that bicarb? Any guesses? Go ahead.
So it took a long time to make bicarb.
Yes. It takes a long time to make that bicarb or regenerate that bicarb. And the opposite of that, it takes a long time to say, hey, kidney, get rid of some of this bicarb. So those metabolic processes take time.
Gene expression.
Yeah,
The gene expression has to change.
right. So as far as respiratory, though, that's a pretty quick process, right? If you're scared, what's going to happen to you? You might start to hyperventilate. That happens like super quick, right? Your respiratory center, the control of your respiratory center can change so fast. And so that's why for the respiratory system, the onset is super quick. And the peak is within hours. Kidneys, it's going to take days to get to the peak. So that's important to know, that the timing of these compensations. And this graph shows it, I think, quite well. So remember, you have all the chemical buffering that happens in your body all the time. And that happens within seconds, right? It's already there in your body, so it's going to happen within seconds. You have the cellular buffering, but then this respiratory compensation will start pretty quick and then maybe peak around 10 to 12 hours. The renal base excretion takes time. So here it says maybe it peaks around a day. To get rid of that base, to get rid of that bicarb. Renal acid excretion takes more time, so up to 3 days.
So it's easier to control a base. So based on this, is it correct to say that acidosis are more common because the responses take longer to control? The acid.
Can you be more specific with that question? Which acidosis?
I would think metabolic.
So you're saying based on this, metabolic acidosis is more common because the respiratory compensation is quicker?
because the renal base excretion is quicker than the acid excretion.
So remember, with metabolic disorders, you have a change in your bicarb. Okay, either you're holding on to it or getting rid of it. That stuff takes a little bit of time. With respiratory, it's much quicker. So I wouldn't get into the thinking of one is more common than the other. Okay, it's really what is causing the disorder. Because really, when we think about it, there's many different causes of a respiratory acidosis, many different causes of a metabolic acidosis. And that's the most important thing, is try to uncover the cause. Because for treatment of these disorders, that's what you want to do, is treat the underlying cause. So if you're scared and you're hyperventilating because you're scared or having a panic attack, you kind of want to calm the patient down, right? Calm them down, control their breathing. That is going to treat that acid-base disorder. So don't get into the don't think about one is more common than the other, because there's multiple causes of each type of disorder.
And yeah, just correcting, I would have said respiratory, because the kidney compensation is a respiratory.
Yeah.
But yeah. Okay.
Okay, so in metabolic acidosis, primary change is a decrease in bicarb, right? Compensation is a decrease in the carbon dioxide. So you're going to hyperventilate. So there's a picture here. So your metabolic acidosis, the primary change is a decrease in bicarb. That's going to decrease your pH. And to compensate, you're going to eliminate carbon dioxide. So this relationship holds true because what you want to do is kind of reverse that change in pH, right? That's kind of what your compensation is trying to do. So if you understand this relationship between bicarb, carbon dioxide, and pH, that's another way to understand the changes. So if you like math or have a mathematic type of mind, maybe this ratio will help you understand it as well.
What does the symbol mean?
This is like almost equal. Not equal, but almost equal. Proportional. So in metabolic alkalosis, the primary change is an increase in base, increase in bicarb, and your body is going to hypoventilate and hold on to carbon dioxide. So it's going to hold on to that acid to compensate for that change in pH. So metabolic alkalosis, you'll have too much base, too much bicarb. That's going to increase your pH. Your body doesn't like that. It doesn't like to be at 7.55. It wants to be closer to 7.4. So it's going to hold on to some carbon dioxide by hypoventilation. So that's going to change the pH closer to 7.4. Does that make sense for metabolic? Is it coming together a little bit?
Clarification.
Yep.
So the body holds on to bicarb, therefore it increases the pH. Or is
There's a process that's making the body hold on to bicarb. So always think of it as there's a cause for the disorder. So there's some cause that's causing the patient to make more bicarb or hold on to bicarb. That's increasing the pH above 7.4 You don't like that. So the body has to add acid. The only way it can quickly add acid is to hypoventilate, retain carbon dioxide. So respiratory acidosis, the primary change is an increase in CO2, increase in acid. Kidneys are going to compensate by increasing base, increasing regeneration of that bicarb, reabsorption of the bicarb, and bringing the pH up to 7.4. So this means that the kidneys, 2 kidneys go in the ureter and the urine, so it's not going to eliminate bicarb. Then finally, respiratory alkalosis. You have some reason that the patient is hyperventilating, eliminating the carbon dioxide, eliminating the acid, causing an alkalosis. So your kidney has to eliminate base or bicarb to compensate for that. And there you see that the kidney is spilling a bunch of bicarb in the urine. Thoughts?
Looking at respiratory alkalosis and metabolic acidosis. I'm looking at the direction of the arrows. Bicarbonate in both cases is down, and PCO2 in both cases is looking down. I just flipped their positions, kept bicarbonate straight on my primary change, and the compensatory change. So it's not whether it's up or down, it's a question of the location. That would make the difference.
So what you want to start off is, again, to take that stepwise approach. Determine the pH. Let's say metabolic alkalosis, pH is high. Then if you uncover a metabolic cause, that means the bicarb is going to be high. So that's primary change in metabolic alkalosis, right? An increase in bicarb. To compensate for that, your body has to hypoventilate, increase carbon dioxide.
So I'm looking at the patient and I say the PCO2 is 20,
Uh-huh.
and I say the bicarb is, let's say, 35. And then, does that tell me anything? Because right now, both metabolic acidosis and respiratory alkalosis will also tell the same story.
So you're saying that the patients...
What I've done, Prof, is you see the ones you put in the bicarbonate for metabolic acidosis. I'm looking at the direction of the arrow. In both metabolic acidosis and respiratory alkalosis, they are both going downward for bicarbonate. And then for alkalosis, the PCO2 are looking downward. So I'm saying, if I'm looking at it by what is more or what is less, I might not be able to conclude whether it is metabolic or respiratory. It's a question of the location of where this increase is taking place. Is that the information?
Well, I have some cases.
Okay.
Patient cases with ABGs, and we're going to go through that, okay? But take a stepwise approach. So first, look at the pH, then determine if it's respiratory or metabolic by the change. But I have some cases that I hope will solidify that a little bit. Right here. So the first one, we're going to take these step by step, okay? We're going to categorize as metabolic acidosis, respiratory acidosis, metabolic alkalosis, or respiratory alkalosis, okay? First one, 733, acidosis or alkalosis? Acidosis, good. It's less than 7.4, right? Remember, 7.4. Acidosis. So we have an increase CO2 and a bicarb that's increased as well. Remember, the normal CO2 is 40. Normal bicarb is 24. So if it was metabolic, would the bicarb be high or low for an acidosis? Low. So it's not metabolic. You know it's respiratory. And does that make sense? The CO2 is high, right? So that goes with respiratory acidosis as a primary problem. Now, the compensation for that respiratory acidosis, too much acid, is to do what? Add or take away base? Add. And that's what's happening with the kidney, right? That's why the bicarb is elevated here.
That's the compensation.
Okay? Is that clicking a little? So the body is compensating by not eliminating bicarb, retaining bicarb, or making new bicarb. Second one, 746, is that acidosis or alkalosis? Alkalosis. Then you go to PCO2, is it high or low? High. Is that alkalosis or PCO2, a high PCO2, is that more consistent with acidosis or alkalosis? Which acidosis. So it can't be respiratory then, right? That's high, and we already said the pH is alkalosis. That's why you always start with the pH. Then you move on to bicarb. Is that high or low, that bicarb of 30? High. So what would you call this as primary? Metabolic alkalosis, right? Does everyone agree with that?
And what's a primary part of the word?
So remember that the primary change is the cause of the derangement in pH. So we have an alkalosis, you have to determine if it's metabolic or respiratory. That's a primary. So in here, it would be a primary metabolic alkalosis.
So we're just keeping the primary and sometimes called metabolic or respiratory and not saying the primary part, right?
Right, it's a metabolic alkalosis, but that's the primary. So that's what you first uncover on the ABG when you're walking through it. Okay? Or is it the primary part that's tripping you?
It's a primary part with stripping me. Yeah. So
Okay.
what would be a non-primary?
So remember what I said is you can have a mixed disorder.
Thanks.
So this is what's causing the pH, right here, metabolic alkalosis. If we go through the steps and calculate an NI gap, well, the patient may have a metabolic alkalosis as primary, but also a secondary metabolic acidosis. Or the patient may have a respiratory acidosis, and so forth. So you always want to start with the primary, and then it gets a little bit more complicated. All right, this one. So remember, I said use 7.4, PCO2 of 40, and a bicarb of 24. So the ranges are important, the normal ranges are important, but when you're looking at acid-base disorders, stick with 7.4, 40, and 24. And this is why. If you did the normal range of pH is what? 7.35 to 7. What? 45. Then you might say this is normal. I wouldn't say this is normal. So I would say this is more on the alkalotic side. It's higher than 7.4. Then you have to look at the PCO2 or bicarb. So the bicarb is low. You're losing base. Is that consistent with the 7.44?
No.
No. Good. If you lost base, you would have more of an acidic.
Acidosis, yeah.
Yep. So then you look at the PCO2, you're losing acid, right? Is that more consistent with the 744? Yes. So this would be a respiratory alkalosis. Okay?
I'm a little bit confused here.
On this one?
Yes. The PCO2 is down. The compensation should be to hold on bicarbonate.
No, right? Because you have 744 alkalosis, respiratory alkalosis. If you hold more bicarbonate, that would cause the pH to go up, which is not good. So your compensation is to get rid of that base. So your pH could go closer to 7.4.
Am I also losing carbon dioxide? I thought I should be having an increase in CO2. So give me more acid.
So the cause is causing the patient to hyperventilate, right? Whatever is causing this acid-base disorder is causing the patient to hyperventilate. And unless you treat that underlying cause, then you're not going to fix acid-base disorder. So your body has to compensate somehow. So let's say the patient is in excruciating pain. They tore their ACL, and it's so painful that they're hyperventilating, right? They're going to blow off some of the carbon dioxide until you fix that ACL or give them pain relief. They're still going to hyperventilate because there's so much pain. So over time, the body is going to get rid of base to compensate. Now that's an extreme case, of course, but that is an example of what happens. Does that make sense? Sorry to use you as an example. All right, 734, acidosis or alkalosis? Acidosis. What's the primary cause? Respiratory or metabolic? Love it. Why?
Bicarbonate is low.
Yeah, it's like.
Bicarbonate is low.
Yeah, 24.
Good. And it compensate. Explain the compensation.
So we have acid. We want to add base to balance that one.
And for the lungs to add base, it can't really add base, so it has to get rid of what?
The acid.
Acid. Good. Awesome. Does everyone agree with that? Okay, so that's simple acid-base disorders.
It's a memory, it's a brain.
It's a brain twister.
Aerobics, right?
Right. Yes. And it takes a while. It takes practice. And I gave you practice problems on Canvas. Okay. So after this lecture, if you want to have some fun Friday, you can do some practice acid-base problems. But in reality, the patients can have multiple acid-base disorders. So they can have a metabolic acidosis and a respiratory acidosis. If that happened, what would happen to the pH? Low, like a lot low, right? I like that. It would plummet. So If you had a metabolic alkalosis and a respiratory alkalosis, what would happen to the pH?
Very high.
Way high. Metabolic alkalosis and a metabolic acidosis.
Balance it out.
Yeah, somewhere in the middle. Same with this one, right? So the patient can have many different acid-base disorders, but you always have to start with the primary. And that's what I want you guys to do. Focus on the primary. Remember, they'll fit in one of these 4 quadrants. Let's take a 5-minute break. One slide.
I feel that.
That should be on your slide. You guys getting it back here?
Oh, yeah.
Yeah. Okay.
No iba a That's you. Oh, that's you. Oh,
Yeah, I understand.
So if the carbon dioxide is driving if the bicarbonate is driving the What are you guys doing? Okay.
Yeah, like tomorrow.
Yeah, almost.
Your favorites, right?
I like it. It's critical care. Yes. I like all critical care topics.
Is that what your specialty is? What? Critical care?
Yeah, I see. Okay.
There's a board.
There is. Yeah, it's a great place. As a practitioner, not a patient. No, I love the challenge. I love the complexity. I love that what we can do and change the patient's physiology. Generally see that in period of time. Like chronic hypertension, right? You put someone on an antihypertensive and have them come back 6 months later. There's a delayed effect, of course, right? I see that improvement. Right. Yeah. And for me, I like that.
Yeah, you see the difference. Are you still practicing?
Not right now, but I've practiced for like 25 years. I see it. It's hard. It's long hours, a lot of patients. So it's fun. All right, let's get back to it. So so we're talking a lot about numbers, right? Acidosis, alkalosis. I think this slide is important because it tells you the consequences of an acidosis, or potential consequences of an acidosis, potential consequences of alkalosis, okay? So for acidemia, cardiovascular, if we take it by organ, you may see impaired contractility, which is not good, right? The heart's not going to contract as much as it should. You can see arterial dilation. So those will both decrease the patient's blood pressure. You may see arrhythmias. In metabolic, you may see insulin resistance, hyperkalemia, some bone issues, neurologic, obtundation, coma with severe PHs, respiratory, you can see respiratory muscle fatigue. For alkalosis, for cardiovascular, it's almost the opposite. So arterial constriction, reduced coronary blood flow, metabolic, some glycolysis, electrolyte wasting, neurologic delirium, tetany, seizures, etc. So, it's important to identify these things and prevent complications. And then to treat the underlying cause, of course. All right, metabolic acidosis, alkalosis. We know, right? We know this. The primary disturbance is in the bicarb for metabolic disorders. So when you think of metabolic disorders, always think of bicarb. The compensation for that change in bicarb is carbon dioxide or respiratory. So we have arrows, and we already went through this scenario, so I'm not going to go through it again. But again, for metabolic disorders, the primary change is in bicarbonate, either high or low, and then compensation is carbon dioxide. So metabolic acidosis we have a decrease in bicarb. So some process in the body is causing the bicarb to go down. It could be maybe whatever is going on is making the patient use that bicarb. And then the pH is going to be down, right? So the increase in hydrogen ion concentration or production, or a loss of bicarb. So maybe there's an injury to the kidneys where it's making the kidneys lose a bunch of bicarb, and that's going to cause metabolic acidosis, or accumulation and impaired excretion of acid. Give me an example of accumulation of an acid. Lactic acid. I love that one. Right? Why do patients develop lactic acid? Could be alcohol, but not drug-induced. Anaerobic metabolism. So many different reasons, right? But if you have decreased perfusion and anaerobic metabolism, the patient is going to have a lactic acidosis, and they're going to have a metabolic acidosis. The other thing about metabolic acidosis is that you can further classify it as a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis, okay? And the calculation for the anion gap is sodium minus chloride plus bicarb. So that's on the BMP, Basic Metabolic Panel, or the Chem7. Normal is about 10. Acceptable range is 8 to 12. So I would say anything above 12 is more consistent with the anion gap metabolic acidosis. So how are they going to present? They're going to present with an acidosis. It's going to be a low bicarbonate. But because of that, you might see an increase in potassium. Your chloride may be normal or slightly elevated, depending on the type of metabolic acidosis. And your anion gap may be normal or elevated, depending on the type of metabolic acidosis. It can be mild, moderate, or severe, mainly based on the pH. Less than 7.14 is not a good thing. I would say that's severe. You don't really need to know mild, moderate, severe yet. So for high anion gap versus non-anion gap, there's many different causes. So for anion gap, if you remember the mnemonic mud piles, M is for methanol, U is for uremia, D is for diabetic ketoacidosis, P is for paraldehyde, I is for iron isoniazid, L lactic acid, E ethylene glycol or ethanol, and then S is salicylates or aspirin. So all these will cause an anion gap metabolic acidosis. Why do we care? Why? You want to fix the patient. So you want to identify why they have that metabolic acidosis and help the patient get better, right? If they have DKA and you're treating the patient for some other reason, the patient's not going to get better until you treat the DKA. The acidosis really isn't going to improve until you treat the DKA. So you really have to treat the underlying cause. For non-anion gap, it's hard up. H is hyperchloremia. A is acetazolamide. R is renal tubular acidosis. That would be more common. D, severe diarrhea. U, ureteral diversion or some type of fistula. And P, post-hypocapnia. So this is to help you differentiate between an anion gap and a non-anion gap and really help you treat the patient. uncover why they're developing this metabolic acidosis. This is usually a consumption of your bicarb. So these processes are consuming the bicarb. These processes, you're losing bicarb. So in RTA, you're losing bicarb in your urine. In diarrhea, you're losing bicarb in your stool. So anion gap, we said that the formula is sodium minus the sum of chloride and bicarb, right? If you do that, it's this teal box here, light blue box. And it's calculating that number of unmeasured anions in the body. If you add hydrochloric acid to the body, you're going to increase the chloride component, right? That should decrease the bicarb because you want to buffer that. And your unmeasured anions should remain about the same as normal. If you add lactic acid to the body, your chloride is probably going to be relatively normal. Your bicarb is going to be lower because it's going to try to correct that lactic acid, and your unmeasured anions are going to increase. So that's what we're trying to calculate, is this blue box. So we have a 57-year-old patient who is determined to be suffering from metabolic acidosis. We have an ABG of 7.18, 32, PCO2 of 32, PaO2 of 98, and bicarb of 12. Its BMP is here, sodium 145, potassium 4.5, chloride 105, bicarb of 12. Is this an anion gap or non-anion gap acidosis? So what's the formula? Great. So someone calculate that, please. $28?
Yes.
Does everyone get 28?
Yes.
Yes. Should be 28. So is that high or normal? High. Anything above 12 is high, right? 28 is very high. So you would classify this as a high anion gap metabolic acidosis. And if you're a practitioner seeing the patient, you should look at mud piles and figure out which one of these the patient has, and then try to treat that underlying cause. We already went over this. This is the compensation. Remember, you have respiratory compensation, hyperventilation for metabolic acidosis. These are the compensatory equations. So there's 2 for metabolic acidosis. You don't need to know this, okay? Maybe if you're on rotation, pull this out and know it for the rotation and impress your preceptor, okay? But for the test, you don't have to memorize the equation. Just know what the lungs are going to do, know which direction the CO2 is going to do in a metabolic acidosis. Which direction is it going to go? The CO2? In metabolic acidosis? Up or down? Down. Metabolic alkalosis. So you have an alkalemia. It's a metabolic cause. So the main component that's disrupted is too much bicarbonate. So there's usually a net loss of protons. There's a net gain of alkali. Maybe you're giving sodium bicarb to the patient. Or there's a loss of chloride-rich bicarbonate-poor fluid. So maybe a GI problem. You can have 2 different types, chloride responsive or chloride resistant, and just causes of each one of those. Metabolic alkalosis compensation is respiratory. So in metabolic alkalosis, you have too much bicarbonate. The respiratory compensation is going to do what to the carbon dioxide? High or low for carbon dioxide? High. High. Good. And again, the equation's there. Respiratory acidosis, the primary disturbance is in the amount of carbon dioxide because it's respiratory, right? Your respiratory center regulates carbon dioxide. The compensation is via the kidneys with the change in bicarbonate. So in respiratory acidosis, you have an increase in carbon dioxide, causing the acidosis. It could be due to decreased ventilation, which there's a number of causes. Give me a cause of decreased ventilation.
Opioid maybe?
Love it. Opiate overdose, right? What's the opiate do to your respiratory center?
Depression.
Slows it down. So once it slows down, the patient's going to start building up carbon dioxide, present with a respiratory acidosis. Happens all the time. I've seen many cases. Other causes, neuromuscular impairment, some medications that cause respiratory depression like sedatives, opiates, there you go. Airway obstruction, so in COPD, right? Chronic obstructive pulmonary disease, they generally have a respiratory acidosis. Could be mechanical ventilation or maybe something like PE or cardiac arrest. Now, in respiratory, there's acute and chronic. Why is there acute respiratory acidosis and a chronic respiratory acidosis? I'm sorry. Because of the delay of the kidneys, the delay of the compensation. That's absolutely correct. So remember, your compensation, kidney compensation, takes hours to kick in and days to peak, right? So there's a delay. So it's helpful clinically if you can identify acute versus chronic. So that COPD patient that has a respiratory acidosis, is that going to be chronic or acute? Probably chronic. Unless they're like, have it, and then all of a sudden they take an opiate and have a secondary thing, and that can be acute, but it's going to be generally chronic. So that will help you when you're assessing the patient. It'll help you if you uncover whether it's acute or chronic, that helps direct your care. And it's all because of that compensation, that kidney response. So acute respiratory acidosis, rapid onset, of course, it's acute, right? You have decreased pH, increased carbon dioxide, and these derangements can be actually pretty impressive. So hypercapnia, retention of carbon dioxide, develops over a few minutes, hours, or days. Patients are usually uncompensated because the kidneys take days to compensate, maybe partially compensated. And like I said, you have a marked acidemia generally because it's an acute process and it's not compensated. So you can see more changes in electrolytes, but certainly an increase in your CO2. Chronic respiratory acidosis, more gradual onset, moderate decrease in pH, moderate elevation in carbon dioxide, and change in bicarb. It's because your kidneys compensated and they corrected that pH somewhat. You may have normal electrolytes in that case because the pH is somewhat corrected.
Do all chronic acidosis start as acute? At
Great.
the beginning, I think.
Great question. Great question. So the question is, do all chronic respiratory acidosis start as acute? No, right? So in that COPD patient, what's the pathophysiology of COPD as far as the lungs and oxygen and carbon dioxide? So that's not an acute process, right? It's a gradual decline in pulmonary function over time. So that's not going to be, they're not going to present as acute process. Does that make sense? So it kind of depends on what's causing it, but I think that's a good example. Respiratory alkalosis, primary cause is too little carbon dioxide. So the patient is eliminating a lot of carbon dioxide. pH is going to be high, and we call that hyperventilation, right? They're breathing faster, their ventilation is higher than normal. Common causes: anxiety, pain, fever, pregnancy, some drugs like stimulants, tumors. That's all central mediated. Hypoxemia can cause it, altitude sickness, and then some peripheral like asthma, pneumonia, etc. Compensation, again, acute and chronic. So both respiratory disorders have acute and chronic. Acute response, those equations are there for your own information. So the stepwise approach, start with the pH. Always look at the pH first, then determine the primary component. So is it CO2? If the primary component is driving that pH change, or if the CO2 is driving that pH change, it's a respiratory. If the bicarb is driving that pH change, it's metabolic. Calculate the anion gap. Always do it to uncover any hidden metabolic acidosis, and then have some idea of the degree of compensation. So for your guys' learning, I just want you to tell me what's going to happen to the compensation. Is it in respiratory acidosis, is the bicarb going to go up or down? But if you like math, you can look at those formulas and look at that. Some points: changes in alveolar carbon dioxide ventilation cause respiratory disturbances. Changes in bicarbonate levels cause metabolic disturbances. Lungs and kidneys compensate for changes in pH. We went over that. Pharmacist's role in acid-base disorders, there's many, right? There's patient examples. So someone with excessive resuscitation with 0.9 normal saline. So if you give someone like 5 liters to 10 liters and 0.9% normal saline, what's in that normal saline?
Salt.
What kind of salt?
NaCl. Table.
Sodium and chloride. Not the same, but yes, sodium chloride. So the chloride component, is that going to be more acidic or basic? Acidic. So you're giving this patient liters and liters of chloride. That's going to cause a metabolic acidosis over time. See it all the time. Excessive use of loop diuretic therapy. How is that going to cause an acid-base disorder? So what? Good, excretion of bicarb. So you're going to lose bicarb, and then what is a disorder? Metabolic what?
Acidosis.
Loss of bicarb. Good. Lactic acid we talked about. Electrolyte management in patient receiving parental nutrition, so you can adjust the chloride and other components. You can actually adjust bicarb or acetate in the TPN. You certainly can help with bicarbonate infusions in a patient with severe acidosis and a pH of, this should be less than 7.1. It's an error in the paper. Overdose we talked about, right? That's very common. Then your assessment, risk of hypochloremic metabolic acidosis, et cetera. So there's a lot of things we can do as pharmacists to help with acid-base disorders. And certainly most of these, I would say, are in the ICU or maybe on the floor. But majority of these are hospitalized patients. All right, ready for a case? AM, a 52-year-old male is found unconscious in a porta potty. What's a porta potty? It's the bathroom thing, right? I don't know what you guys call it here. That's what we call it, porta potty. At the scene, AM was noted to be hypothermic and unresponsive. The patient's temperature at the time was 79.4. That low? Is that low? That's pretty low, very low. This is a real case, guys. This happened. The patient was brought to the ED, where he's intubated, warmed with blankets and saline. All right, so you have a nice picture of a guy found in a porta potty. He's really cold. Vital signs, temperature is low. Respiratory rate is super low, 6. So does that like ring in some bells with the acid-base disorder? Maybe. Blood pressure, is that low?
Yes.
That's really low, 40 over 15. Heart rate is high. He's 64 kilos and 5'10". Past medical history, we don't know because he's obtunded.
At 40-15, is he still alive?
He was when he left the ICU.
No, in clinical practice at 40-15, will he be alive?
Huh?
I mean, in real clinical practice,
Yeah.
with BP of 40-15, they will still be alive.
This is a real case.
Real case.
Real case. I mean, it happened in January.
Okay.
So pH is 7.25, PCO2 at 43, bicarb at 19. This is his Chem 7 or BMP, CBC, white count, hemoglobin, platelets. So what do you want to look at? pH. Look at the pH. What's his pH? 7.25. Low. All right. But what else is important that I didn't point out on this labs? Lactate. All right. Remember the steps. pH. Determine primary cause, respiratory or metabolic. Always calculate the anion gap, and then tell me what the compensation is going to do. Rule 1, presence of acidemia or alkalemia is determined from pH on the ABG. You can have acidosis and alkalosis at the same time, but you can only have one respiratory process. Does this patient have acidosis or alkalosis?
Acidosis.
When acidemic or alkalemic pH is discovered, attribute the primary process to either respiratory or metabolic. If pH is 7.4 and bicarb is less than 24, then it's metabolic. If the pH is high and the bicarb is high, then it's metabolic. If the pH is less than 7.4 and the PCO2 is high, then it's respiratory acidosis. If the pH is greater than 7.4 and the PCO2 is less than 40, then it's respiratory alkalosis. So this pH is 7.25, acidosis. Then we look at the CO2 or the bicarb. You can pick whatever one you want. Which one is it?
Respiratory.
This is going back to some confusion maybe. So PCO2 is high or low?
Higher side.
And is that like in line with the low pH?
In line with the hypoventilation.
Okay. Bicarb is high or low?
Low.
Low. And the degree of change of the pH, is that a small change or a large change?
Pretty large.
Pretty low.
I would say pretty large, right? So this increase of only from 40 to 43, that's not going to change the pH that much. Okay? So we're calling this a primary metabolic acidosis. But he has more than that.
Because the HCO3
Is low, very low, I would say. Okay?
And we don't take in consideration the CO2 because it's like only 3 points.
Right.
Of 40.
And we're gonna come back to the CO2. So we're not gonna forget about it. So the primary process is a metabolic acidosis. Does everyone agree with that? All right, what do you want to do with metabolic acidosis? Calculate the anion gap, right? Elevated anion gap could be ketoacidosis, DKA, lactic acidosis, renal failure, toxins. Normal anion gap is listed there. Do you remember the anion gap calculation?
Sodium minus bicarbonate minus chloride.
So chloride plus bicarb, right? So sodium minus chloride plus bicarb, normal is 8 to 12. Anion gap of greater than 20, I would say is severe. Some processes is going on. Now I didn't tell you this, but you should correct it for albumin, because albumin is an unmeasured anion. So if you have a patient with low albumin, then it should be corrected. Again, if you want to impress your preceptor, know the correction. You don't have to know it for the test.
What should correct it? Albumin should be corrected.
Why?
You said albumin should be corrected.
The anion gap should be corrected for hypoalbuminemia, because albumin is an unmeasured anion. So normal albumin is 4. If it is less than that, it should be corrected. And it's going to increase your anion gap.
So for each gram drop, you add 2.5.
To the anion gap calculation. So we'll do that. So calculate the anion gap. There's your BMP there. Do you guys remember which box is what? You didn't get that? Or, you did? Okay, good. Sodium, potassium, chloride, bicarb, CUN, creatinine, and then glucose. So what's a bicarb? 19.
Second goal.
What's a chloride?
95.
95. And sodium is what?
143.
Okay.
Minus 114.
$29.
29?
Yes.
Did everyone get 29?
Yes.
Should be 29. Albumin is 3. Uh-oh.
So that's 7 point, add 7.5, that would be
So-
36.5.
Hold on a second. Normal is 4.
Oh, no, minus 4.
So it's a 1 gram drop from 4 to 3. So you add what?
2.5.
2.5 to this calculation. So 29 plus 2.5. Okay? So your corrected anion gap was 31.5. That's super high, which you would expect based on how this guy presented, right?
We said that more than 20 would be a very high, a severe.
More than 20 is high, severe. Yes. So mud piles. methanol, uremia, DK, paraldehyde, isoniazid, lactic acidosis, ethylene glycol, salicylate. Do you think he has any one of these?
Is lactic acidosis because of the hypo?
He had lactic acid. All right, so I forget what his. All right, so he had metabolic acidosis, right? The primary change is a loss of bicarb. You would expect his CO2 to do what? Go up or down?
Compensatory.
So he has
Compensatory.
less base. He's losing base, right? He's losing base. His pH is more acidotic. It's low. You expect the CO2 to do what?
Increase.
No.
Who says up?
Losing base and so.
So he already has an acidosis. If you added carbon dioxide to that, would that cause a more acidosis or less acidosis? More. That's not good. That's not compensated, right? So you would expect the patient to be eliminating carbon dioxide, right? But he's not. It's actually high. And that's why the pH is so low. Okay, so what we're seeing here in the real patient is not what we expect. So why is that?
Because he was unconscious and he was not mentally.
Love it. Remember, his respiratory was 6. He was unconscious. He's barely alive. That's why he has a respiratory acidosis on top of that metabolic acidosis. That's how your compensation can help you undercover other acid-base disorders. Isn't that
In this case,
cool?
the body was not able to do what we would normally
What was
try to do.
expected? Yes. So the compensation would be hyperventilation, right? And he can't do that because he's obtunded. Maybe he took something. So he has a mixed acid-base disorder, and the PCO2 is higher than expected. If you do those equations, you would calculate that his expected PCO2 is 33, and it's above 40. So, so he has a high anion gap metabolic acidosis with a respiratory acidosis present. And does that make sense? And if you go back to the case, we just talked about it, it kind of does, right? So this guy came in, if I remember right, he actually ingested some antifreeze, which is ethylene glycol, which is on the mud piles as well. So he has ethylene glycol toxicity causing this whole problem that he has.
Is this like because of drug, or he was trying to commit suicide?
I don't know why you originally took it. You could take it because you don't have access to alcohol, so you go with antifreeze. It's an alcohol. Unfortunately, it has more toxic effects than just like other alcohol, like wine or beer or whatever. Questions? You guys want to be on the beach?
Yes.
Yeah, sure.
Where is that? Was this one you?
This, yeah, I took that. That's in Vieques.
Wow.
That's beautiful.
That is
Some of the most beautiful sunsets I've ever seen there.
That's beautiful.
Thank you. All right. Thank you. Thanks for coming to class. I'm going to post those practice problems. Please do them. And then I'll post the key as well.
Thank you.
Thank you. You as well.